wonderful presentation on ChatGPT by, by Ben. So that might make you wonder that the future is all about the future is all about robots delivering healthcare using these AI-driven models, right? But I'm here to talk about a different future, a future where we can deliver evidence-based healthcare to improve the outcomes of our tiniest patients by involving families meaningfully. A future where the NICU is more human again. So, in our NICUs, we take a lot of pride in promoting ourselves as proponents of family centered care. But this philosophy goes out of the window when it comes to critical medical decisions, where a doctor walks into the room and tells the family, we're going to use this drug that protects your baby's brain, or use that drug to protect your baby's lungs. And when you ask why, well, it's standard NICU policy based on evidence. So that creates this perception of evidence based care where a bunch of physicians come together and they discuss their ideas, brainstorm causes, identify their aims, and to achieve their aim, they identify their primary and secondary drivers that lead to their change ideas, which are the actual healthcare interventions that are implemented as standardized NICU policy, QI bundle, guideline, whatever the name you call it. And that is the reason why we've been taught to believe that the sole purpose of a clinical practice guideline or a QI bundle is to standardize care and reduce practice variation. But doesn't that directly contradict our philosophy of providing patient and family centered care? And that's probably the reason you and I both at some point have conveniently deviated from a guideline for the benefit of the patient and has just shrugged it off saying, oh, it's just a guideline. And if you and I have both done it at some point, then it's probably time to take a step back and think closely about this phrase practice variation. What are we actually trying to achieve here? So Sutherland and colleagues have suggested that what we're actually trying to achieve through a guideline is to cut down on unwarranted clinical variation that stems from unjustified deviation from evidence base, one that is based on the provider's needs and preferences. But on the other hand, a guideline or a QI bundle should be flexible enough to provide some degree of warranted clinical variation that is still based on evidence, but is tailored to the local context and the patient's values. And if you and I both believe that that should be the true purpose of a guideline, doesn't that directly conform to the basic principles of practice of evidence based medicine that has been defined as the judicious use of the best available evidence, that is, doing the right thing, things that are proven to work, and doing it right in the local context, in your own unit, to find out what works in your own unit, while carefully considering the outcomes that actually matter to families. But unfortunately, most clinical guidelines in neonatology do not consider this third pillar of evidence based medicine. And therefore, regardless of how much they promote themselves as evidence based, they are not practicing evidence based medicine. Now, you could argue that, well, these principles were developed in the adult world. Do they really apply to an intensive care setting like the NICU? So, over the next few minutes, I would use this example of indomethacin prophylaxis to try and argue whether these principles still apply in our field. So, if you look at data from Cochrane Neonatal, to date, more than 5,000 preterm infants have been randomized to clinical trials of PDA prophylaxis. That includes more than 3,000 infants in trials of indomethacin prophylaxis. So one would expect that by now we would have a definite answer on whether to adopt or discard this drug from our clinical practice. But unfortunately, confusion still remains. We know that indomethacin is a drug that accelerates closure of the ductus, and therefore, through its effect on the ductus or through direct effect on the brain, it helps reduce bleeding inside the brain. We are unsure about its effects on the lungs, while there are concerns, especially from observational studies, on its effect on the gut and the kidneys. But regardless, due to its potential beneficial effect on the brain, it has been adopted into routine clinical practice by a number of centers across the United States. For example, if you look at this recent QI project from University of Alabama, they have standardized the use of single-dose prophylactic indomethacin along with a number of other standardized interventions and have demonstrated a pretty significant reduction in the rates of severe IVH and death. Similarly, if you look at another recent QI project from California, they've also standardized the use of prophylactic indomethacin and have demonstrated a tenfold reduction in the rates of severe IVH. But these are some isolated examples of success stories and do not present a true picture of what's happening across the United States. That is seen a slow decline in the use of prophylactic indomethacin over the last 10 years due to valid concerns around nephrotoxicity, effect on the gut, brain, and also the fact that the reduction in severe IVH did not really seem to translate into meaningful clinical benefit when it comes to neurologic outcomes. And in addition, in recent times, there has been the emergence of competing prophylactic agents, such as hydrocortisone. Now, if we look at this widely publicized QI project from the UK called the parental, that has standardized a number of evidence-based interventions to reduce mortality and brain injury in extremely preterm infants. It includes prophylactic and hydrocortisone, but excludes indomethacin. Which brings us to this rather uncomfortable question: why do we all differ in opinion? Are we not reading the same evidence? Well, seems to be more and more unlikely in our field given the wonderful work these platforms have been doing to keep us up to date. So, the evidence does not apply to our local context, could very well be the case, especially with indomethacin, which I recently came to know is not even available in a lot of centers in the UK. Third is a rather tricky question. Do we really understand the meaning of the evidence that we are reading? And unfortunately, that may not always be the case when we see decisions being made and interventions being adopted or discarded solely based on a p-value threshold without a proper appreciation of the magnitude of the effect size in relation to what's clinically meaningful. And even if we assume that we are reading the same evidence that applies to my context and we've managed to understand that correctly, even that interventions have differential impacts on different outcomes, and what's important to you may not be important to me, and we never ask the families what's important to them. Therefore, decisions are often made based on how we as healthcare providers value outcomes in our local context. But you might argue that no, we do involve families in our QI projects. But I would counter argue, is that enough for all clinical decisions? So again, let's go back to this question of prophylactic indomethacin versus hydrocortisone. So we recently explored this question through a project on developing a clinical practice guideline on the use of prophylactic cyclooxygenase inhibitor drugs in extremely preterm infants. So essentially, we had three objectives. First, we compared the different prophylactic agents through a large network meta-analysis. Then we presented the evidence to families to evaluate their values and preferences on the use of these drugs and also on the use of prophylactic hydrocortisone. And then we convened a guideline panel that not only included physicians, but also experts in evidence synthesis, grade experts, and most importantly, families of extremely preterm infants and also adults who were themselves born extremely preterm to formulate these guideline recommendations using the GRADE evidence to decision framework. So, what the framework essentially helps you to do is it has three steps. First, obviously, we formulate our guideline question, but most importantly, right at the outset, we involve all stakeholders, including parents and an adult born preterm, to identify outcomes that are important for decision making. Then we curate the evidence using a systematic review and rate the certainty of evidence using the standard grade methods. And finally, convene the panel to move from the evidence to clinical decisions. Now, given this was done as a larger project that would guide us to make clinically meaningful decisions, we spent a lot of time trying to define what is a meaningful benefit or harm. And we used the partially contextualized approach where we essentially predefined a priori for each outcome in absolute and relative terms what we meant by a trivial effect, a small effect, a moderate, or a large effect for each outcome. So, for example, a small reduction in death will have a very different magnitude compared to, say, a small reduction in GI bleed. And we felt this was very important to define because that's how we balance benefits and harms at the bedside. Then, once we had defined our thresholds of benefit or harm, we then assessed the certainty of evidence using the standard grade methods where we assigned a certainty of evidence for each of these outcomes. So, for example, when we look at the analysis from our NME for prophylactic indomethacin, we found that there was moderate certainty of evidence to suggest that there was a moderate reduction in death, a small reduction in severe IVH, while evidence from randomized trials did not give us a clear signal in terms of harm with respect to GI outcomes. So, as the next step, we then went on to present this evidence to families through this cross-sectional mixed method study, where we conducted the study in two phases, a pilot phase, and then we moved on to the larger study where we include 40 participants, mostly parents of extremely preterm infants, in addition to 9 adults who were born extremely preterm, with a median gestation age of the participant or their child at birth being 26 weeks, which ensured that every participant has had a lived experience of extreme prematurity in the NICU. So then, based on the feedback from parents in the pilot study, in the formal values and preferences study, we asked the participants to rate these outcomes on a scale of 0 to 100. And we found that, not surprisingly, death was unanimously rated as the most important outcome, followed closely by severe IVH. And interestingly, BPD, which still remains the most common primary outcome in contemporary neonatal trials, was actually rated quite low by the families. We then moved on to the next phase where we presented the evidence to the families using these infographics and asked them that based on this evidence, whether they would have chosen this medication for their child. So interestingly, we found that when presented as the only option, majority, 90%, would choose prophylactic indomethacin because of its effect on the critical outcomes of severe IVH and death, which is very different from the trends in practice in the United States and other parts of the world. But then, to make matters a little bit more complicated, we presented them with an option, the option of low-dose prophylactic hydrocortisone. We got this evidence from the recent IPD meta-analysis by Schaffer, which showed that there was moderate certainty of evidence to suggest that prophylactic low-dose hydrocortisone resulted in a moderate reduction in chronic lung disease and a large improvement in survival without chronic lung disease. So when presented with this option, 2/3 of the participants who said yes to indomethacin now flipped their responses and said that they would choose hydrocortisone because they valued that mortality benefit way over the benefit of severe IVH reduction with indomethacin, which was very, very interesting for us. So with these perspectives, We then brought back our panel to move from this evidence to recommendations using the evidence to decision framework. Now, what this framework forces you to do is not only consider the best available evidence, but put that in the context of what matters to families and also the local clinical context, such as the resources, whether it's acceptable, feasible, equitations. And then the panel has to provide their judgment on each of these domains to come to a final strength and directional recommendation. So, for example, for this topic, our panel acknowledged that yes, there was a small but definite reduction in severe IVH and a probable reduction in death. There was a possible slight increase in BPD, while there was no real effect on GI outcomes or long term neurodevelopment. So, the scale, for the panel at least, slightly tilted in favor of indomethacin. The scale would have tilted strongly in favor given the strong parental preference for its use, but the fact that two-thirds of the participants had flipped to hydrocortisone when that was made available tilted the scale again back in favor. So, in other words, indomethacin was not a clear winner. So, based on this, our panel provided a weak recommendation in favor of using prophylactic indomethacin in extremely preterm infants at the highest risk of severe IVH, with a strong emphasis on shared decision making with families when possible. So, in other words, after all that elaborate exercise, the most evidence based recommendation on prophylactic indomethacin essentially was talk to families if possible before you decide. Now, how does that help my colleague who's trying to build this QI bundle on reducing severe IVH? So, just to give you a real life example of the problem, this is data from my own center, where our rates of death of severe IVH has been rather embarrassingly higher than the national average over the last few years. Our rates of BPD had been lower than the national average. We have been rather proud of it, but even that has crept up in the last couple of years. So, should our QI group introduce prophylactic indomethacin or go for prophylactic hydrocortisone? Because as per standard traditional QI teaching, once you introduce an intervention, you have to stick to it and track its use because you cannot deviate from it. But given the most evidence-based recommendation mandates shared decision making with families, rather than adopting or discarding this intervention from your QI bundle, can we not make offering the opportunity for shared decision making the change idea itself? And this thought process not only applies to this example, but a lot of other examples in neonatology. Say, a use of postnatal corticosteroids in chronically ventilated preterm infants. So, with these examples, I would pose the question to the QI champions here that can we not imagine a future of QI that aligns more with the principles of evidence-based medicine, where if the most evidence-based recommendation mandates shared decision making, we make offering the opportunity of shared decision making with the family our process measure, thereby promoting the warranted clinical variation that we talked about. While if the most evidence-based recommendation strongly recommends an intervention like caffeine, like surfactant, antenatal steroids, then you go ahead and standardize that as NICU policy and track its implementation as your process measure using standard QI methods, thereby reducing unwarranted clinical variation. So, food for thought for the future. So, with this, I would like to wrap up with one of my favorite cartoons by Paul Glasso on the leaking evidence to decision pipeline, where to improve outcomes, we need to start off by doing the right things. We need to start with the best available evidence. Then we need to ensure that the evidence is applicable to my local context. That is, do it right locally. And while doing so, we have to keep in mind that we have carefully considered the values and preferences of our family so that they agree to our practices. And therefore, QI bundles, guidelines that are developed using the concepts of great evidence to decision framework that nicely brings together all these three pillars may just help you to achieve your QI goals in the most evidence based, family centered way. Thank you.